This lecture is about endometriosis. Let's start with the basic. Endometriosis is defined as estrogen-dependent chronic inflammatory lesions composed of endometrial-like tissues outside the uterus. Endometrium is a special type of mucosal membrane lining inside the uterus. It undergoes changes during menstrual cycle. If fertilization doesn't occur, the endometrium sheds, causing menstrual bleeding. Now, the endometriosis is misplaced endometrial cells. The classic theories to explain this include retrograde menstruation, where menstrual blood flows backward into the pelvis, and coelomic metaplasia, where cells transform into endometrial-like tissues. However, immune dysfunction likely plays a role too. Failure to clear these ectopic cells allows them to implant and grow. Now the question is, who gets endometriosis? Approximately 10% of reproductive aged women are affected, but this number rises to 20 to 50% in women with infertility. Key risk factors include a family history, like a 6 to 9 times higher risk if a first degree relative is affected. Early menarche. What is menarche? Menarche is the time of first period. In early menarche, if first period occur in less than 12 years, then this term is called an early menarche. Some researchers also suggest that this age is between 10 to 11 years. The other factor is short menstrual cycle, less than 27 days, or nulliparity. Nulliparity is a trait or a character in which we say that a female have never given birth. Then for that woman we use the word nulliparity. Importantly, it is not exclusive to women of reproductive age. It has been found in adolescents and post-menopausal women on hormone therapy. Now, let's see the clinical presentation of endometriosis. The hallmark and symptom for endometriosis is pelvic pain, but not all pain is the same. Like it can be chronic pelvic pain that persists beyond menstruation. Pain can be cyclic, that is related to menstrual cycle, and this pain can be non-cyclic. The other clinical symptom is clinical dysmenorrhea that worsens over time. Dysmenorrhea is pain due to abnormal contraction of uterus during menstrual cycle. Deep dyspareunia. The pain during intercourse is called dyspareunia. Another clinical feature is dyschezia. That is related to painful bowel movements or difficulty in defecation. The other factor that is not written here is dysuria, that is especially during menses. Infertility is related to 30 to 50% of the cases. If there is an infertility, then we also can go for endometriosis. Like we can say that this is also a symptom or sign of endometriosis. On physical exam, you might find tenderness in the posterior vaginal fornix. Where you find tenderness? In the posterior vaginal fornix. Palpable nodules in the ligament between sacrum and uterus. That ligament is called uterosacral ligament, or rectovaginal septum, the rectum that is present between rectum and vagina. But remember, 20 to 25% of patients are asymptomatic, diagnosed incidentally during surgery for other reasons. Let's move toward the investigations and diagnostics. Imaging is used to confirm this condition. Transvaginal ultrasound is first line. It is excellent for detecting endometriomas, those chocolate cysts in the ovaries. As you can see in this ultrasound, something resembling chocolate cyst is shown. It is characterized by a dark, thick fluid that is actually old blood with the cyst. The other technique, MRI. MRI is reserved for deep infiltrating endometriosis, like bowel or bladder involvement. If there is any other organ involvement, then we use MRI technique. Laparoscopy is the gold standard for diagnosis and treatment. Direct visualization reveals classic lesions, powdered black spots, red flame-like lesions, or white fibrotic plaques. You can see in this laparoscopic image that this is resembling to red flame-like lesions. Now, what are the laboratory findings? The first finding that can make a diagnosis, but it is not specific. CA125, it can be elevated in this condition, but keep in mind that this is non-specific. Now, for the diagnosis, for the definite diagnosis, what we do laparoscopy with histology. If the histology of tissues taken from outward of uterus resemble those inside the uterus, then we can say that this is endometriosis. We stage endometriosis using a classification called ASRM classification, which guides prognosis and treatment. Let's have a concise detail on ASRM classification. The American Society for Reproductive Medicine classify endometriosis on the basis of a scoring system. The ASRM system uses a scoring system to quantify the extent of endometriomas, with points awarded based on the number, size, and location of lesion. The first stage is minimal, and it is characterized by minimal disease with minimal lesions. Lesions are on the peritoneum, ovaries, and fallopian tubes. The scoring range for the first stage is between 1 to 5 points. The second stage is called mild. Involves mild disease with some lesions present, includes superficial or deep endometriosis and some adhesions or scars. Scoring for stage 2 range is typically between 6 to 15 points. The third stage is called moderate. Moderate stage represents moderate disease with more extensive lesions and adhesions, includes both superficials and deep endometriosis and more significant adhesion formation. Scoring range is typically 16 to 40 points. The fourth stage is severe, and it indicates severe disease with widespread lesions, extensive adhesions, and significant involvement of pelvic structures. Include deep endometriosis, significant adhesion formation, and potential involvement of other organs. Scoring range is more than 40 points. If you want to go in details, you can go and visit the website of ASRM, like American Society for Reproductive Medicine, and you can find the further detail there. Now the million-dollar question is, how do we manage the endometriosis? The goals are pain relief, disease suppression, and preserving fertility. First of all, we go with medical therapy. First-line drugs are NSAIDs combined with hormonal suppressions, like combined oral contraceptive pills or progestins. In progestins, what we can use medroxyprogesterone. Combined oral contraceptives like the birth control pills actually reduce hormone production and reduce tissue growth. The second line are gonadotropin hormone releasing agonists like leuprolide with add-back therapy of low-dose norethindrone to protect bone density. Actually, these drugs reduce the female hormones in which estrogen is also present. You all know that the estrogen is responsible for the bone health. Now, norethindrone, when used with these drugs, actually protect bone density by decreasing bone loss and promoting bone formation. The second approach is surgical therapy. In surgical therapy, we can use laparoscopic excision, and this is ideal for severe pain, large endometriomas, or failed medical therapy. Other options include hysterectomy with oophorectomy. These are the last resort for refractory cases, but recurrence is possible if ovarian tissue remains. Hysterectomy surgery removes uterus and cervix, and this patient does not have periods, and it prevents further surgeries. Oophorectomy removes one or both ovaries. These two procedures are performed together. Now the key point is treatment must be patient-centered. A 22-year-old desiring pregnancy needs a different approach than a 40-year-old. After the treatment, what is the prognosis? Endometriosis is a chronic and recurrent disease. 20 to 40% of cases come again. However, pregnancy and menopause often reduce the symptoms. This is the end of this lesson, and if you have got any value from this lesson, give a thumb up.